अस्सलाम वालेकुम, क्या हाल चाल है आप सबका? ठीक ठाक। अच्छा, तो आज मैं ना अपना एक केस प्रेजेंट करने लगी हूँ, लॉन्ग केस। ठीक है, उसमें ये होगा कि मेरा तो कॉन्फिडेंस आ जाएगा, मुझे प्रेजेंट करने में थोड़ी मदद हो जाएगी, एक दफ़ा प्रैक्टिस हो जाएगी और आप लोगों को पता चल जाएगा कि हाउ व्हाट इट एक्चुअली इज़, होता क्या लॉन्ग केस। ठीक है, घर से। ठीक है, तो वही मैं घर से पढ़ने लगी हूँ अभी। ठीक है, प्रैक्टिस करने लगी हूँ। सो देखते हैं। ठीक है, अच्छा। My patient name Shameen Bibi, 73 years old female, admitted in medicine unit 2 in Dash Hospital via emergency on date आ जाएगी 13 March 2023 with complaints of chronological order में आपने complaints बतानी है। यूँ पहली complaint is the pain in chest on eating या जिसको dysphagia कहेंगे for 5 months। ठीक है, सेकेंड इज़ एब्डोमिनल डिस्टेंशन फॉर 2 months एंड पीडल एडीमा फॉर 2 months। ठीक है, एब्डोमिनल डिस्टेंशन का मतलब होता है कि पेट फूल जाना, भर जाना, पानी भर जाना उसमें। और दूसरा है पीडल एडीमा, इसको कहते हैं पाँव सूज जाना, पाँवों में सोजश हो जाना। ठीक है, अब हिस्ट्री ऑफ शी इज़ नॉर्मल glycemic hypertensive patient for 5 months. She is a diagnosed case of hepatitis C for 5 years. The hepatitis C was associated with jaundice, dark colored urine with usual constipation, reduced bowel habits and reduced diet. It was not associated with diarrhea, vomiting, nausea or itching. The jaundice resolved itself since she didn't take any medicine or treatment for it. Then she started developing abdominal distension 2 months back, which was insidious in onset, gradual, started from flank, now extended to the whole abdomen. Distension is progressing from mild to massive ascites. No aggravating factor, only relieved by paracentesis in her previous stay in Pakpatan 20 days back, which the ascites is effective. She experienced bilateral progressive persistent irrespective of day and night extending below knee pitting edema for 2 months. The abdominal distension is associated with pedal edema and chest pain on eating. The chest pain was gradual in onset, progressive burning pain for 5 months, which could be a sign of GERD, associated with anorexia, relieved by not taking food, aggravated by taking food or taking meal. ठीक है, she also has a history of constipation, which she said that she only passed stool 1 or 2 times per month. Also reduced appetite and bleeding per rectum for 2 years. On general review, there is a significant weight loss, reduced appetite, disturbed daily routine, mobilized lethargic patient, no anasarca. On CNX examination, headache present, sense of smell, hearing and taste were intact, altered sensorium and disturbed regular sleep pattern. ठीक है, there was no numbness, tingling, weakness, fits, blackout, vertigo, ataxia or paralysis. There was a history of dizziness and reduced vision also. On CVS systemic review, there was no palpitation, no chest pain, no orthopnea, but dyspnea without exertion was present. Respiratory, there was no shortness of breath, no asthma, no cough wheeze, no chest pain, dyspnea present and no night sweats. On GIT systemic review, she was experiencing constipation for 2 years, passing 1 or 2 stool per month, abdominal pain present, bleeding per rectum present for 2 years, no jaundice, weight loss for 1 year and no diarrhea, no vomiting. No tremors, no heat or cold intolerance, polyphagia, polydipsia, no night sweats, no hair loss, and on endosystemic review. Reproductive, she had menopause 25 years ago. On MSK review, musculoskeletal review, muscle weakness was significant, muscle pain positive, muscle wasting was positive, no joint pain or swelling, no arthritis, no restrictive movement. On skin, there were no rash, no itch, no color spots, no allergy. On renal review, no frequency, urgency, hematuria, burning micturition, incontinence, pyuria, hesitancy, no periorbital edema, but pedal edema or ankle edema was present. Past medical history: she is hypertensive patient for 5 months, taking medicine for it, but was unaware of medicine. Okay, there was no history of other medications. There was no drug allergy history. There was no history of any accident. Only cataract surgery was done of both eyes 1 year ago. Her personal history includes she is non-smoker and non-alcoholic woman, mother of 9 children, so all alive and healthy. Her family history says that there was no history of diabetes, sugar, cardiac or liver diseases in family. There was no history of contact history of TB, hepatitis B and C. Poor socioeconomic, moderate living on house of 3 rooms using tap water. ये हो गया सारा इसका हिस्ट्री, ठीक है। अब इसके बाद हम जाएंगे जीपी पे, जनरल फिजिकल एग्जामिनेशन पे, ठीक है। जो ऑन जनरल फिजिकल एग्जामिनेशन माय पेशेंट वाज एन एल्डरली वुमन, malnourished, lying uncomfortably in bed with IV cannula in left arm. She was well oriented in time, place and person. Normal language intact, recent and remote memory. She is vitally stable with pulse 90 beats per minute, BP 130/80, respiratory rate 24 breaths per minute, and temperature 91.7 degrees Celsius. On general physical examination, there was no pitting, no splinter hemorrhage, no clubbing, no koilonychia, no leukocythemia, no cyanosis but pale nails. No sweating on hands, palmar erythema absent, ocular nodes or Hurberton nodes were not present, no swan neck deformities, muscle wasting was present, no contractures, no lesion on skin, dry and lax skin, no tattoo or sign of IV drug abuse, no subluxation, ulnar deformity or Z deformity. Cervical axillary lymph nodes were not palpable and not enlarged, no fetal hepaticus, no parotid swelling, no cyanosis or pallor in eyes, no petechiae, no spider nevi, hair texture and distribution is normal. Dental hygiene was poor, but no sacral edema, only pedal edema. On inspection of abdomen was protuberant, not moving with respiration, umbilicus is central and everted, no visible veins, pulsations, stria or stretch marks. Scar of paracentesis was present in left lower quadrant. ठीक है। There was no sign of fat or wrinkling of skin or malnourished. On palpation, abdomen was tense, non-tender or no rebound tenderness, ठीक है। Liver, spleen, kidney were not palpable. Liver upper border was in fourth intercostal space. Its span cannot be assessed due to ascites. Abdomen was dull on percussion. Fluid thrill is positive. Shifting dullness was absent. Bowel sounds were audible on auscultation. On chest inspection, chest was not visible from foot side. From bedside, chest is elliptical. Respiration was respirating with accessory muscles. Respiratory rate 24 breaths per minute. 24 breaths. There was no deformity, pulsation, visible veins, scar marks on chest. Chest movements were bilateral, ribs were prominent due to muscle mass loss. On palpation, there is no tenderness, no crepitus, equal chest expansion. Vocal fragmentus was resonant. Trachea was palpable in the center. Apex bead was palpable in the fourth intercostal space, mid-clavicular line or area. Thyroid was not palpable. On percussion, chest was resonant. On auscultation, vesicular breathing was heard with low intensity, equal in duration in inspiration and expiration. No pleural rub was present. Also, the vocal fragmentus was equal on both sides. On CVS examination, pulse was 90 beats per minute, regular and normal in character. On inspection of chest, poor cardiovascular system, there were no visible pulsation, scar mark or dilated veins. Apex bead was in fourth intercostal space, mid-clavicular region. No heave or thrill was palpable. JVP was not raised. On auscultation, first and second heart sounds were normal. Normal heart sounds were normal. Heart sounds can be heard in all 4 precordium areas. Third and fourth heart sounds or murmurs were absent. There was no pericardial rub. There was no pericardial rub. Okay. On CVS examination, higher mental functions were intact, which means she had a good knowledge, good fund of knowledge, good recent and remote memory, aware of time, place, and person. All cerebellar functions were intact, which means there was no nystagmus, there was no rebound tenderness, no pendular knee jerk, no scanning speech, can walk. Also, there was no dysdiet. According to my case, my differential diagnosis are chronic liver disease or hepatocellular carcinoma. My diagnosis is hepatitis C induced liver cirrhosis with ascites due to portal hypertension. For this case, I would like to do investigations which include CBC, ELISA and PCR for HCV RNA, albumin, PT, INR, blood sugar range, HbA1c, alpha fetoprotein, spiral CT scan, chest X-ray, abdominal ultrasound, diagnostic paracentesis to check out serum ascites albumin gradient SAG. Also, paracentesis would go for cell count, abdominal concentration, total protein concentration, blood culture, color, and WBC's counts, RFTs, LFTs, and that's all for my investigation. For treatment, since the patient is admitted for abdominal distension, which is caused by ascites, we rule out all the 5 F's of ascites, which include fluid, fetus, fat. Okay, if we are giving diuretics to her, तो हमारा गोल ये होगा कि अगर उसको पेरिफेरल एडीमा, जैसे कि हमने कहा है पाँव पे सोजिश है, पेरिफेरल एडीमा, पीडल एडीमा है, सो देन आवर गोल इज़ 300 to 500 ग्राम पर डे. पीडल एडीमा नहीं है तो 300 to 500 ग्राम पर डे, लेकिन अगर पीडल एडीमा या पेरिफेरल एडीमा है तो 800 to 1000 ग्राम फ्लूइड रिमूव होना चाहिए फ्रॉम बॉडी. तो हम उसका यूरिन आउटपुट, अगर तो पेशेंट बेड रिटर्न है तो फिर हम उसको कैथेराइज करके उसका यूरिन आउटफ्लो चेक करेंगे कि कितना बैग में यूरिन प्रोड्यूस हो रहा है. अगर डायूरेटिक्स भी काम नहीं करते दैन वी विल डू थेराप्यूटिक पैरासेंथेसिस. पहले हमने की थी डायग्नोस्टिक, अब है थेराप्यूटिक, जिसमें हम उसको पहले एल्ब्यूमिन देंगे, थेराप्यूटिक पैरासेंथेसिस करेंगे विद एल्ब्यूमिन. उसके अलावा हमारे पास नेक्स्ट रिजॉर्ट बचता है टिप्स इज़ ट्रांसजगुलर इंट्राहेपेटिक पीवी शंट. ठीक है, पीवी शंट, इसमें फिर हम शंट बना देते हैं जिसके थ्रू हमारे पास फ्लूइड ड्रेन होता रहेगा. और लास्ट है हमारा लिवर ट्रांसप्लांट के, ताकि क्योंकि लिवर का मसला है, लिवर इज़ नॉट फंक्शनिंग वेल, तो हम लिवर ट्रांसप्लांट कर देंगे, जो कि लिवर पाकिस्तान में होना तो बहुत मुश्किल है, लेकिन ये इसका बनता है आखिरी हल. तो ये सब मेरा था केस. अल्लाह के अच्छे नंबर मिलते हैं. अल्लाह हाफ़िज़.